Thank you, sir, for kind introduction and good morning to you all. Thank you, KSM, for the invitation. Okay, today's my topic is Progestogens in modern gynecological practice. This is what is I meant by Progestogens, and this is what is I meant by modern gynecological practice. I have nothing to disclose, no conflict of interest other than taking images from Google. So this is the layout of my lecture. A brief history and the biochemistry and classifications of progestogens, and I will define the terms. Then I am focusing on two entities, the fourth generation or the latest generation of progestins, and a smart device which is levonorgestrel releasing intrauterine system. So in those two aspects, I'll be discussing the mechanism of action, the clinical uses with adverse effects, and I will summarize the take-home messages at the end. He is the boss, Prof. Willard Allen, who invented progesterone. The name has derived from progestational steroidal ketone, progesterone. This is the terminology. The progesterone term is used for natural hormone, which is secreted by in females corpus luteum, placenta, in pregnancy, adrenal cortex, and testis in males, or in both males and females. The progesterone name is we are using for synthetic preparations, which has progesterone-like activity. The progestogens is for both progesterone, which is natural, plus the synthetic progestin. Common diagram from Harper's and Gannon's and from medical student time, which I am not going to discuss. Right, this is the classification. First generation, second generation, and third generation and fourth generation of progestins or synthetic progesterones. Out of these, I'll be focusing on the fourth generation because my topic is progestogens or progestins in the clinical practice. But I will be discussing the second generation progesterone, which is levonorgestrel, but with the even though I'm discussing the second generation as NIVES, because I'm discussing the intrauterine system, the nicely designed device which we are using in many aspects of gynecology. Right, so this is the drospirenone molecule and this is the LNG-IUS device. We'll focus on the first generation progestins in the first half of the lecture. Why this is smart? Because it is a spironolactone derivative. Because of that, it has anti-mineralocorticoid activity. It has 10 times more potent than the original spironolactone, because it is a derivative of original spironolactone. Same time, this drospirenone has, or the fourth generation progestins, they have the anti-androgenic activity. Two more things. It is very much similar to naturally occurring progesterones, which leads to less adverse effects. So these are the properties which we are using in our clinical practice. The mechanism of action, everyone knows. It inhibits the FSH and LH in the hypothalamus pituitary and ovarian or gonadal axis, and it has the effects on the local effects on the end organ, which is the uterus, endometrium, cervix. That's how it prevents the that's how it becomes a sort of contraceptive agent. Cervical hostility, inhibit endometrial receptivity, which prevents implantation and inhibits sperm motility. Because of it blocks the aldosterone receptor, and it exhibits the anti-mineralocorticoid activity or effects, and it inhibits binding of dihydrotestosterone to the receptor and also the androgen synthesis, and increases the sex hormone binding globulin, which directly reduces the free form of androgens. By doing those, it has the anti-androgenic activity. Then we'll go move to the clinical uses. So these are the uses. The top entities in gynecology and the last three in obstetrics. So it helps in abnormal uterine bleeding, endometriosis associated pelvic pain, premenstrual syndrome, PCOS, hirsutism, and we use in treating acne and we use in contraception as well as in HRT. Then in obstetrics, preterm labor prophylaxis. There's a place in recurrent pregnancy loss or recurrent miscarriage, and we use progestogens or progestins in assisted reproductive techniques or IVF. So we'll take one by one. I will give a very brief description in each entity. AUB, this is the division for medical students. Palm coin for causes in terms of etiological factors for AUB or abnormal uterine bleeding. Palm coin is a short form. Palm is for structural causes, where we are mainly the treatment mode will be surgical, but for functional we use progestins. PALM stands for polyp, adenomyosis, leiomyoma, and malignancy. COIN is for coagulatory disorders, ovulatory dysfunction, endometrial causes, iatrogenic. N stands for not yet classified. So progestin is mainly for functional. Functional AUB is mainly following ovulatory dysfunction leading to hormonal imbalance in the normal cyclical pattern of the in the female in the reproductive life. So these what we usually using for any functional AUBs, sort of summary, but it is individualized assessment, and then only we are deciding the treatment mode. Usually less than 18 AUB, that is mainly because of HPO immaturity. We give COCP in that age group, second decade of life. Then third and fourth decade of life, we use COCP. Sometimes we can use progestins only. And after the 40 or the fifth decade of life, we use COCP and LNG-IUS or cyclical progesterone. If the medical treatment fails, we do the endometrial assessment and maybe we treat surgically as well. This is the evidence for AUB, the place of drospirenone in AUB in the reproductive life age group. It reduces the total mean amount of bleeding and the spotting days by using the drospirenone. And the scheduled bleeding was lighter with the drospirenone plus this in COCP in combined oral contraceptive pills. You get both estrogens and progesterone. And now the pattern is very low dose estrogen, usually 20 to 30 micrograms, and these progesterones does the marvelous job in reducing the blood loss in the menstrual cycle. Moving to the pain, especially the pain associated with endometriosis. What is the role of progestins? Just a brief introduction of endometriosis. It is a chronic. It is the presence of endometrial stroma and glands, both in places other than the endometrial cavity, or basically ectopic endometrium. It is all about pain and subfertility. We talk endometriosis in terms of pain, maybe cyclical dysmenorrhea, or if the disease has progressed, which leads to chronic pelvic pain and pain while having sex, dyspareunia, and the other entities subfertility associated with endometriosis, which is very difficult to treat. Prevalence is 10%, and in the subfertile female group it is even up to 30 to 50%. The problem is chronic progressive nature and very high recurrence rate. This is the evidence for COCP or the fourth generation progesterone containing combined oral contraceptive pills for pain associated in endometriosis. There is significant reduction in endometriosis associated pain, and it also improved other complications of endometriosis like endometriomas or chocolate cyst formation. What is the place of fourth generation progesterones in PMS? PMS is a very distressing physical, behavioral, and psychological. It causes those symptoms, but there is no organic or psychiatric disease. Those symptoms, especially in the luteal phase of the female menstrual cycle. And another typical feature is those symptoms disappears with the menstruation. During that luteal phase, female becomes a different character. In our setup, we don't diagnose PMS. It is very minimally addressed area in our country or in this part of the world. In Caucasians or Western world, it is a big topic. This is the evidence for place of fourth generation progesterones for PMS. It is superior to placebo for improving symptoms associated with PMS. It improves the overall quality of female's life. 50% of the month improves by this marvelous fourth generation progesterones. What is the place in PCOS? Again, this is the commonest endocrine disorder in females. This is the commonest, I am repeating, this is the commonest endocrine disorder in females in the reproductive life. That is not diabetes. Okay. So what is the place? This is the evidence for COCP or fourth generation progesterone containing COCP in PCOS. COCP we may combine with metformin in PCOS plus lifestyle modifications. Those things achieves better control of blood pressure, correct carbohydrate metabolism in women with PCOS and other metabolic disorders compared with cyproterone acetate containing COCPs. Cyproterone acetate is an anti-androgen which is there in some COCPs. But evidence says the fourth generation progesterones are superior to CPA. The place in hirsutism or excessive hair growth. This is the evidence for drospirenone versus cyproterone acetate. Both drospirenone and cyproterone acetate containing COCPs provide similar improvement in body hair growth. Both well tolerated without causing serious side effects, adverse effects. But response is slightly faster in patients treated with ethinyl estradiol plus drospirenone containing COCPs. Both are okay for cyproterone acetate as well as drospirenone. Both are fine for hirsutism. Another entity because of high androgens and it is associated in PCOS as well, both hirsutism and acne. This is the evidence for fourth generation progesterones in acne. The combined oral contraceptives containing ethinyl estradiol and drospirenone provides an effective treatment option in mild to moderate acne. What about fourth generation progesterones in contraceptive pills? Now the trend or the fashion is very low dose estrogen which contains 20 to 30 micrograms of ethinyl estradiol. But the problem is lower the estrogen dose, poorer the cyclical control, but contraceptive efficacy remains normal, remains same. With lower the estrogen dose, there's a high chance of poor cycle control. But adding drospirenone or the progesterone component an extended regime rather than going for 21/7, going for 24/4 regime helps in controlling the cycle. And this fourth generation progesterone, because of less adverse effect profile, this is much more popular in COCP in the 21st century. The 24/4 regime has a shorter pill-free period, and with better ovarian suppression, less chance of withdrawal bleeding or hormonal withdrawal, less side effects due to the fourth generation progestins, and because of anti-androgenic, anti-mineralocorticoid properties, this is suitable for female with different metabolic profiles like hypertension, diabetes, obesity, especially central obesity, or gynaecological type, android type obesity. What is the place of drospirenone in HRT? In postmenopausal, the postmenopausal life is females 1/3 of the life. In Sri Lanka, mean age of reaching menopause is 51. The range is 45 to 55, and when compared with the life expectancy of a Sri Lankan female, on average 1/3 of females' life is post-reproductive, or she is lacking estrogen. So what we have to replace is estrogen, but the problem is if the patient's uterus is intact, we can't just give the estrogen alone because it causes endometrial hyplasia and at the end endometrial malignancy. That's why we have to combine it with the progesterone, but the concern is progesterone related side effects. This patient is suffering from estrogen deficiency symptoms like hot flushes, mood changes, but adding progesterone sometimes may cause behavioral changes, mood changes, sort of bloating, breast tenderness. So we have to consider, we have to give, while we are giving the estrogen, we have to give a progestogen with a minimal side effects or adverse effects. So the policy of giving the estrogen is we have to give the lowest possible dose and the shortest duration because of some estrogen related concerns like breast malignancy. Because of the very much similarity between the drospirenone and naturally occurring progesterone, with its anti-mineralocorticoid and anti-androgenic properties, this has become the best progesterone supplement in HRT. Okay, those are the things, those are the entities that we are using this progestins in gynecology practice. Then I am discussing 3 entities related to obstetrics, but some are again overlapping with the gynecology. One entity is preterm labor. Preterm labor is an entity which is on the rise. The world figures as its incidence is around 10%. And the preterm labor carries all the neonatal complications, like say mainly the neonatal mortality and morbidity, which has financial impact on the country's health economics. The progesterone, it is an anti-inflammatory hormone, so it inhibits pro-inflammatory cytokines and delay cervical ripening. The labor is an inflammatory process. Labor is an inflammatory process. So progesterone is the one which maintains the pregnancy and which maintains the uterus in a relaxed form. Progesterones are, if the progesterones are depleting, that means she is more towards labor, or uterus is ripening, cervix is ripening and uterus is starting to contract. So we use progestogens if there are risk factors for the preterm labor in females. The other tool that we have is cervical cerclage. Those are the 2 entities in the world to prevent preterm labor, which is on the rise. So the risk factors like say past history of preterm labor, past history of cervical incompetence with a second trimester miscarriage, or patient had a cervical surgery like we are taking large loop LEDS biopsy or cervical cone biopsy for cervical precancer. So those are the risk factors, but mind you, the preterm labor, the majority of females who are going to preterm labor or cervical incompetence, they don't have any risk factors. Recurrent miscarriage or recurrent pregnancy loss, there's a place in supplementing progesterone in the first trimester till the placenta takes over the progesterone synthesis. There's a place for micronized progesterone in the first trimester, bleeding in the background of previous pregnancy loss. Progesterone again you need for endometrial receptivity, very early pregnancy, as a very early pregnancy supplement. The placenta is fully functioning maybe from 10 to 12 weeks onwards. Till such time, the corpus luteum is the main progesterone source, you know, medical listeners. And if you think there's a deficiency and say she is bleeding with the previous pregnancy loss, there's a place for progesterone supplementation, especially in the first trimester. In IVF, that is, we artificially manipulate the female cycle. We suppress pituitary LH by giving GnRH agonist or antagonist. So there is no corpus luteal stimulation after conceiving. So from outside we have to give a progesterone supplement till the placenta functions properly. That means till after 14, after 12 weeks placenta will be functioning properly. So till such time, support the embryo with progestins. So adverse effect profile, there are no much serious side effects. The one concern is thromboembolic phenomena. The evidence remains unclear. The DVT risk increases, especially when we combine with estrogen. There is no much evidence for progesterone alone for DVT. So risk increases when the progesterone combined with estrogen, and when there are other risk factors like smoking, obesity, or advanced age. However, we know we use progestogens in COCP. That means it's as a birth control. So risk of VTE by progestins is very much lower when compared to risk of DVT in pregnancy and postpartum. So by giving COCP, we prevent unintended, unplanned pregnancies. Directly, we prevent the risk of DVT. So it's at the end again beneficial. Hyperkalemia just because of anti-mineralocorticoid activity. So we are a bit cautious giving progestins in CKD patients. Breast cancer. Progesterone alone will not increase the risk of breast CA. It is combination of estrogen and progesterone. Again, it's very minimal risk. There will be additional breast cancer if 1,000 females are using this what you call combination in HRT for 1 year. So there will be only additional 1 case of breast CA for 1,000 women per annum. Sort of very low risk. So what are the take-home messages related to this beautiful 4th generation progestin? Natural, very much similar to natural progesterone. It has anti-mineralocorticoid and anti-androgenic activity. The multiple uses in obstetrics and as well as in gynecology, and it is an agent in modern combined oral contraceptive pills as well as in HRT. Right, the second part of the lecture, I am moving to the levonorgestrel, which is a 2nd generation progestin, which is coming in this beautifully designed device. It's called levonorgestrel releasing intrauterine system. It was introduced in 1970s as a mode of contraception, but we are now using in many other aspects. The particular cylinder of the device contains 52 milligrams of levonorgestrel, and this beautiful job is done by the rate control membrane which is there, which releases on average 20 microgram of levonorgestrel inside the uterus on daily basis. At the beginning it is 20, towards the latter part, close to 5 years, it drops to 11 micrograms per day. This device is designed for 5 years as a mode of contraception. What it does is it suppresses the endometrial glands, and it causes, because it is secreting progestogens, it causes thickening of cervical mucosa. You can see the lower diagram how the endometrium is suppressed. It has an effect on ectopic endometrium, which is inside the lining of the uterus, as well as on the ectopic endometrium, which is there in endometriosis. These are the mechanisms of action. It is because endometrium is the trophic hormone to the endometrium is estrogen, which causes endometrial proliferation. The counteracting hormone is the progestin or progestogens. So what are the modern gynecological users of this device? It's very versatile device. Again, a list of users, and most of the things are again overlapping with the entities that I described in my first half, the users of fourth generation progestins in gynecology and obstetrics. Again, we use in AUB, endometriosis, adenomyosis, limited use in fibroids. Again, there's a place for PMS, endometrial hyplasia, and there's a again limited use in early stage endometrial malignancy when the patient wants to preserve her uterus, and it is a mode of contraception. This is the original introduction of LNG-IUS came to the world as a mode of contraception at the beginning, and this is again in HRT. Okay, AUB. There is significant reduction in mean blood loss, and the amount of blood loss is clinically relevant. It doesn't reduce by the menstrual blood loss. Doesn't reduce the blood loss by say 2-3 milliliters. There is a clinically relevant reduction of menstrual blood loss, and this effect is sustainable. That is the beauty. This is evidence: menstrual blood loss at the end of 3 months, 6 months, and 12 months. At the end of 1 year, there is a reduction of 97% of mean menstrual blood loss. This is evidence for increase in hemoglobin level and serum ferritin level. Again, at the end of 3 months, 6 months, and 12 months. We can see a difference even at the end of 3 months, and significant difference at the end of 12 months or 1 year. When we compare, we'll compare the LNG with the other medical treatment options as well as surgical treatment options for AUB or HMB. LNG-IUS, the efficacy of achieving the reducing the blood loss, menstrual blood loss, this is the highest. This is the top in the list. Reduction by 87%, 0.5. Danazol we don't use much because of adverse effect profile. And oral progestogens, 63% reduction. COCP again almost same. With tranexamic acid, which is non-hormonal, reduction is around 48%. So LNG-IUS will reduce, is the best treatment for functional AUB. This is the evidence. The comparison between LNG-IUS and other medical treatment modes in achieving the improvement in social life, psychological health, physical health, work-related activities, daily routine, relationship, family life. In all aspects, this improves at the end, it's all about females' quality of life. Then we'll compare the LNG-IUS versus surgical options. The microwave endometrial ablation we don't have in our country. Evidence from other countries. The comparison between endometrial ablation versus LNG-IUS. Reduction in menstrual blood loss was similar, and improvement in quality of life did not differ. We don't have endometrial ablation in our country. What we are doing is this thing, hysterectomy. It's a very good alternative to hysterectomy, and we should try before going to hysterectomy definitely, or at least as an interim method while patient is waiting for hysterectomy. In the world, after introduction of LNG-IUS for AUB purpose, the world hysterectomy rates has gone down drastically, and it should be considered before this invasive hysterectomy, and obviously less cost to the patient as well as to the country. The place of LNG-IUS in AUB, the summary: higher user satisfaction rate, higher quality of life, sustainable improvement of symptoms, and it is cost effective. The other entity, just like fourth generation progestenes which I discussed, place of LNG-IUS in endometriosis. Significant reduction in menstrual pain, significant reduction in chronic pelvic pain if the disease has progressed. That particular female is experiencing pain on daily basis, which impairs female's quality of life significantly, whether the female is working or non-working. And say if you are doing a surgery, laparoscopic surgery for endometriosis, insert the LNG-IUS, that will postpone the recurrence, that will reduce the recurrence rate as well. And this device releases the progestogen only inside the uterus. Very minimal systemic absorption, so there are no adverse effects related to progesterones, or there are no anti-estrogenic effects, because it is designed to release inside the uterus. This is the evidence for blood loss and reduction in pain in endometriosis with LNG-IUS at the end of 6 months, 3 months, 6 months, 12 and 24 months. Another entity, adenomyosis, which is presence of ectopic endometrium within the myometrium. We label it as adenomyosis. This entity is usually reluctant to or resistant to medical treatment. Most of the time they may need a surgical management, but we can suppress. We are not going to cure the adenomyosis. Cure is, hysterectomy. The cure for endometriosis is again a radical surgery where we have to remove the uterus, ovaries, tubes, and all the peritonia which has the ectopic endometrium or endometrial deposits. But we can suppress the disease, both endometriosis and adenomyosis, with this device. The evidence for LNG-IUS in adenomyosis significantly reduces the abnormal bleeding associated with adenomyosis, improves the pain score, improves the hemoglobin level, improve the health-related quality of life, and it is a definite practical solution to hysterectomy. Fibroids, there's a limited place in LNG-IUS for leiomyoma or fibroids. Fibroids are the commonest benign gynecological tumor in female reproductive tract. The prevalence is 20%. 1 in 5 females are having fibroids. The beauty is only 50% are symptomatic. So you can calculate how many fibroids in the audience. It is 1 in 5. LNG, it is not that much effective as functional or idiopathic AUB, but there's a place for LNG-IUS, especially when there is no cavity distortion or there is no cavity or minimal cavity, endometrial cavity distortion by the fibroid. Then there's a place for my LNG-IUS for fibroid associated AUB. The problem with if there is a cavity distortion with the fibroid, there's a high expulsion rate of the device. The LNG-IUS expulsion rate among women with fibroid is up to 20%, but it is less. It is up to 3% when there are no fibroids in the uterus. What is the place of LNG-IUS in PMS? Thing is, we are targeting to supplement the female with estrogen, but we need to add progestogens or any progesterone to prevent the risk of endometrial hyplasia. Then if you are giving the progestogens orally, there will be systemic absorption and progesterone related side effects. So that's why there's a place for this device which releases progesterone only inside the uterus where there is no systemic side effects. So to prevent endometrial hyplasia, when we are supplementing the female with estrogen in PMS, there's a place for LNG-IUS because it is only locally acting. Endometrial hyplasia, which is now we label as EIN, just like CIN. Everyone knows CIN. It is cervical intraepithelial neoplasia, which is a precancer for cervical cancer. This entity, endometrial hyplasia, now world is labeling as EIN, endometrial intraepithelial neoplasia, which is a precancerous stage for endometrial cancer. That is because of unopposed estrogen activity on the endometrium, especially with obesity, android type obesity, where there is a lot of visceral fat, which is the largest endocrine organ which secretes because of aromatase activity. It is a good source of estrogen, and if the female is anovulatory, say PCOS, that female is not producing the corpus luteum. So estrogen is dominating, or otherwise it is unopposed estrogen activity, which leads to endometrial hyplasia, sort of highly common entity in the society. So this entity has a low malignant potential but may resolve spontaneously, and this precancerous stage, just like SIN, will respond into medical management. So this is caused by the high estrogen activity or unopposed estrogen activity. So what we have to give is progesterone. This LNG-IUS gives a very high concentration of progestins inside the uterus or where there is the precancerous stage. There is less systemic adverse effects and it reverses the hyperplasia. There's a place for very early stage ovarian cancer, but this is a very crucial decision, especially if the patient wants to preserve the fertility. The standard treatment for endometrial cancer is we are removing the uterus, ovaries and the tubes, but early clinical stage cancer with strong desire to maintain fertility, hormonal therapies and alternative LNG-IUS. Put the LNG-IUS and reassess the endometrium in 6 months' time. The other option is giving high dose oral progestins, which carries all the adverse effect profile of progestogens. Whatever it is, if patient wants to preserve the uterus, manage medically, ask the patient to go for pregnancy after reversal, then we need to do the complete surgery or hysterectomy after completion of the family. The original use of LNG-IUS as a sort of contraception. Now, the fashion or the trend in contraception in the world is LARC, long-acting reversible contraception. The name says the advantage. It's long-acting and it is reversible. The other beauty is it is controlled by us. The main, what we are talking in terms of maternal morbidity mortality in our country is unmet need of contraception. Patient is not coming to a healthcare institution or not seeking medical advice for contraception. Here it's long acting, reversible. If we are inserting LNG-IUS, it is not patient led. The action will be there for 5 years and patient need to come back to the healthcare institution for the removal. Even though it's designed for 5 years, obviously we can remove at any point and next cycle female can get pregnant. And the other beauty is all the non-contraceptive benefits I discussed, the female is like a bonus to the female. Very low failure rate with the both typical and perfect use, 0.1%. And a sort of disadvantage, the copper IUCD we can use as a mode of emergency contraception. Say a female had unprotected sexual intercourse up to 5 days or 120 hours, we can insert the copper IUCD as a mode of emergency contraception, but LNG-IUS will not help as a mode of emergency contraception because contraceptive effect takes 7 days after insertion. What is the place in HRT or ERT? I mentioned earlier what the female needs is estrogen. So actually it should be ERT, estrogen replacement therapy. We are giving progestins to prevent the adverse effects of estrogen on the endometrium. So this provides the beautiful design provides the endometrial protection when the female is receiving the estrogen for her postmenopausal symptoms. I told the postmenopausal symptoms are almost similar to progestin related adverse effects. Bloating and like faintishness, mood changes, hot flushes, those things are not there with the local progestins, which is released by this device only inside the uterus. So this is a very good mode of progesterone replacement in ERT. It protects from endometrial hyplasia. And I want to highlight the LNG-IUS as a mode of contraception or for any other gynecological use. It's designed for 5 years. But for this purpose, when we are protecting the endometrium in ERT, it is designed for 4 years. So we have to remove the LNG-IUS after 4 years and reinsert if patient wants to continue with the same plan. Adverse effects of LNG-IUS: unscheduled bleeding. However, it will be there only for first 3 to 6 months. We have to buy time. It will get settled for the rest of the 5 years. Infection, it is associated with any intrauterine device, especially within first few weeks of insertion. Expulsion rate, it is high with multiparous as well as in fibroid uterus. Uterine perforation is 1 in 1000. It is there with any IUD or intrauterine device. Unacceptable health risks or absolute sort of contraindication for LNG-IUS: uterine anomaly, maybe congenital like Mullerian anomaly, or maybe acquired like fibroids. Active cervicitis vaginitis, active inflammation or infection is going on. Cervical dysplasia we can't assess the AUB pattern. Sometimes we may think this is iatrogenic or the LNG-IUS inserted. Same reason we can't use in AUB of unknown cause. Current breast cancer, it's a sort of category 4 contraindication, and obviously pregnancy. Category 3, where the complications or risks outweigh the benefits. Those are postpartum within first month, because of high expulsion rate, and any immunosuppressive conditions, active viral hepatitis, progesterone, some may have effects in liver, liver tumors, and current index thromboembolic phenomena are sort of category 3 contraindications. What are the take-home messages with LNG-IUS? It's a very good luck, originally designed for as a long-acting reversible contraception. There are lots of non-contraceptive benefits, so we use in a lot of gynecological conditions. We use in ERT or estrogen replacement therapy. Usually, this device is well tolerated. You may experience a little bit iatrogenic AUB, especially within first 3 months, but that will get settled by time or managed symptomatically. Patient satisfaction is quite high when if we do the proper counseling and patient education. Patient will be very much happy because she may avoid a hysterectomy. It has improved the overall female's health related quality of life, and in the world it has reduced a lot of hysterectomies and related cost.